Hey, how's it going, everyone? This is FixerMed. Welcome back to my high-yield biochemistry review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. This will be part 18 of my multi-part video series covering the entire discipline of biochemistry from start to finish in a comprehensive yet high-yield manner. So without further ado, let's go ahead and get started on today's content. Today I'm going to be mainly describing neurocutaneous disorders, also known as Phakomatoses. So without further ado, I'm going to start off with neurofibromatosis type 1, known as NF1. The genetic basis for NF1 is primarily the NF1 gene. It is inherited in an autosomal dominant fashion. It is located on chromosome 17. Some main clinical features found in this neurocutaneous disorder is neurofibroma, café au lait spot, hyperpigmented macules, axillary groin freckling, Lisch nodules, known as iris hamartomas, pheochromocytoma, optic nerve glioma, oligodendroglioma, ependymoma. Sorry about that. So as you can see, there's also an illustration of some of the symptoms of NF1. Moving on. Next, I'd like to talk about neurofibromatosis type 2, also known as NF2. The genetic basis for this disorder is primarily underlied by the NF2 gene, is inherited in an autosomal dominant fashion, is located on chromosome 22. Some main clinical features of NF2 include bilateral acoustic schwannomas, and meningioma. And I have a picture of NF2 symptoms here. Moving on. Next, I'm going to talk about tuberous sclerosis. The main genetic basis for tuberous sclerosis is the TSC1 gene, known as hemartin, on chromosome 9, and the TSC2 gene, known as tuberin, on chromosome 16. Some clinical features of tuberous sclerosis include periventricular nodules, tubers, on MRI of the head, seizures, adenoma sebaceum, angiofibromas, subingual fibromas, renal angiomyolipoma, cardiac rhabdomyoma, hypopigmented macules, Ashley spots, hyperpigmented velvety lesions, shagreen patches. And I have an example of a patient suffering from tuberous sclerosis in the image here. Moving on, I'd like to talk about Vaughan-Hippel-Lindau syndrome next. The main genetic basis that underlies Vaughan-Hippel-Lindau is found on the VHL gene. It is inherited in an autosomal dominant fashion. It is located on chromosome 3. Some main clinical features of Vaughan-Hippel-Lindau include cerebral retinal hemangioblastoma, bilateral renal carcinoma, pancreatic cysts, mutations which cause constitutive activation of hypoxia-inducible factor. And I have a picture here that describes some of the clinical features that can be found on Vaughan-Hippel-Lindau syndrome. Next, we have Sturge-Weber syndrome. The main genetic basis for this disease is not inherited. It's primarily somatic mosaicism of the GNAQ gene. Some clinical features of Sturge-Weber syndrome include port wine stain birthmark, known as nevus flemmius, may also present as a violaceous papules and temporal distribution. Leptomeningeal angioma presents as a seizure and glaucoma. Let's go ahead and move on to some questions. Which of the following is the most likely diagnosis for a 20-year-old male with a 6-year history of seizure disorder accompanied by flesh-colored papules on the bridge of the nose and in the nasolabial folds? All right, I think I gave you guys enough time. Let's go ahead and move on. The patient's presentation, including a history of seizures, flesh-colored papules on the face, and the age of onset, is highly indicative of tuberous sclerosis, TSC. TSC is an autosomal dominant disorder caused by mutations in the TSC1 Hamerton gene on chromosome 9 and the TSC2 tuberin gene on chromosome 16. Subependymal or periventricular nodules seen on MRI, hypopigmented macules, Ashley spots, hyperpigmented velvety lesions, Sjogren patches, cardiac rhabdomyoma, renal angiomyolipoma, and subungual fibromas are characteristic features of TSC. The mention of ridding movements in a young child during sleep further supports the diagnosis of seizures, a common manifestation in TSC. Therefore, the correct answer is tuberous sclerosis. Let's go ahead and see why the other answer choices are incorrect. Neurofibromatosis type 1, NF1, is characterized by cafe au lait spots, neurofibromas, and Lisch nodules. However, the flesh-colored papules on the face and the other described features are not typical of neurofibromatosis type 1. Neurofibromatosis type 2. Neurofibromatosis type 2 is characterized by bilateral acoustic schwannomas and meningiomas. The presentation described, including flesh-colored papules, is not consistent with neurofibromatosis type 2. Von-Hippel-Lindau syndrome. Von-Hippel-Lindau syndrome is associated with cerebral, retinal hemangioblastomas, renal cell carcinoma, and pancreatic cyst. The clinical features mentioned do not align with VHL syndrome. Sturge-Weber syndrome. Sturge-Weber syndrome presents with a port wine stain, nevus flammeus, and leptomeningeal angioma, but the flesh-colored papules described are not typical of this condition. Next question. We have a 25-year-old male who presents with intermittent headaches, palpitations, and visual disturbances. On examination, there are retinal hemangioblastomas, and imaging reveals bilateral renal cell carcinomas. Genetic testing confirms a mutation in the VHL gene. Which neurocutaneous disorder is most likely responsible for this patient's clinical findings? I think I gave you guys enough time here, so I'm going to go ahead and move on to see what the correct answer is. If you need more time, please feel free to pause the video. The patient's symptoms, including headaches, palpitations, and visual disturbances, along with retinal hemangioblastomas and bilateral renal cell carcinomas, are characteristic of Von-Hippel-Lindau syndrome. Von-Hippel-Lindau is an autosomal dominant disorder caused by mutations in the Von-Hippel-Lindau gene on chromosome 3. The mutation leads to the constitutive activation of hypoxia-inducible factor, contributing to the development of various tumors, including retinal hemangioblastomas and renal cell carcinomas. Therefore, the correct answer is D, Von-Hippel-Lindau syndrome. Let's go ahead and see why the other answer choices are incorrect. Neurofibromatosis type 1. NF1 is characterized by cafe au lait spots, neurofibromas, and Lisch nodules. The clinical findings described, including retinal hemangioblastomas and renal cell carcinomas, are not typical of NF1. Neurofibromatosis type 2, NF2, presents with bilateral acoustic schwannomas and meningiomas. The symptoms and tumors mentioned do not align with NF2. Tuberous sclerosis, TSC. TSC is characterized by seizures, hypopigmented macules, and specific skin lesions. However, the described retinal hemangioblastomas and renal cell carcinomas are not consistent with TSC. Sturge-Weber syndrome. Sturge-Weber syndrome is associated with a port wine stain, nevus flammeus, and leptomeningeal angioma. The clinical findings, including renal cell carcinomas and retinal hemangioblastomas, do not match those of Sturge-Weber syndrome. Let's go ahead and move on to the next question. We have a 16-year-old female that presents with a facial port wine stain, nevus flammeus, involving the right cheek and upper lip. The patient has a history of seizures, and imaging studies reveal leptomeningeal angiomas. What neurocutaneous disorder is most likely responsible for this patient's clinical findings? Alright, I think I gave you guys enough time here. I'm going to go ahead and move on. If you need more time, please feel free to pause the video now. The patient's presentation, including a facial port wine stain, nevus phlemeus, and leptomeningeal angiomas with seizures, is characteristic of Sturge-Weber syndrome. Sturge-Weber syndrome is not inherited and is associated with somatic mosaicism of the GNAQ gene. The port wine stain, often involving the trigeminal nerve distribution and leptomeningeal angiomas, contribute to the clinical features, including seizures. Therefore, the correct answer is C, Sturge-Weber syndrome. Let's go ahead and discuss why the wrong answer choices are wrong. NF1 is characterized by café low spots, neurofibromas, and Lisch nodules. The presence of a port wine stain and leptomeningeal angiomas is not typical of NF1. NF2 presents with bilateral acoustic schwannomas and meningiomas. The facial port wine stain and leptomeningeal angiomas described do not align with NF2. Tuberous sclerosis is characterized by seizures, hypopigmented macules, and specific skin lesions. However, the presence of a facial port wine stain and leptomeningeal angiomas is not typical of TSC. Incontinenta pigmenti. IP is an X-linked dominant disorder characterized by skin changes in different stages. It does not typically present with a port wine stain or leptomeningeal angiomas, making it an unlikely diagnosis for this case. That will do it all for today's lecture. If you have any questions, comments, or concerns, please feel free to leave them in the comment section below. If not, this is FixerMed signing off. Goodbye and good luck studying, everyone.